Hi. So I am currently waiting for Dr. Alliston Kennedy for us to get started on the AlmaMAC radio show this afternoon. So today we have a special guest, Dr. Alliston Kennedy, and she is a researcher conducting COVID research at McMaster University. So I'll be chatting with her, and I am very excited to have her join us this afternoon. And if you don't know me, I'm Shawn. Shawn Hercules, one of the co-hosts of the AlmaMAC radio show, happens every Thursday at McMaster University, CMU. And we have Alliston, yay! Phew. I think she's joining. Ah! Hi, Alliston.
How are you?
I'm okay. How are you?
I'm good. I'm good.
Yeah. How?
Yeah. Can you hear me okay?
Yeah. Yeah, I can.
Okay, perfect.
Yeah. Can you hear me?
I guess.
Great. Great. Welcome.
Thanks. I'm so excited to do this.
Yeah. Pardon?
I said thank you for inviting me.
Oh, yeah. No, last week I was like, it would be really great if we had a COVID researcher from Mac to talk about this. And my mind instantly went to you.
Oh, wait, thank you.
So how are you doing in this interesting time right now?
It's crazy. It's like day to day. I can't keep up with how things are changing and trying to stay motivated and keep working. But at the same time, I'm at home and there's only so much you can do here. So, but so far, so good. Yeah.
Yeah, I feel
How about you?
all of the above. It's not easy, but trying to find ways to be productive. And I see people talk about like trying to get routines and stuff, but I don't know if that's working for me, trying to find a routine. I just work when the energy hits.
Mm-hmm.
When the concentration.
I don't get too stressed out if I don't make it to my desk like first thing in the morning. I'm like, when I'm ready, I'm ready.
Yeah, that happened to me this morning. Like I had a plan. I was like, Shawn, you're getting out of bed. But like I set my alarm for 9 o'clock, which already is late, but I set my alarm for 9. I was like, okay, I'll be up from 10. I'm going to do X amount of work from 10 till this time. That did not happen.
Especially with like being in the academic setting and especially coming out of like grad school where you're just used to all this work all the time and just having something to do, to have to switch that so dramatically is really hard.
But I have
really,
more
really
stuff
hard
to do, it feels like, now. So there's that.
My to-do list is so crazy long and I'm trying to like cut it down piece by piece and it just gets longer. So
yeah. But first of all, welcome again to the show. So we're just gonna first start off with a few introductory questions, like who is Dr. Alliston Kennedy?
So philosophical.
Okay, so like you're doing a postdoc right now at McMaster in Dr. Don Bodish's lab?
Yep.
Yes. But what did you do before that? How did you even get there?
Oof. So I did my undergrad at Laurentian in Sudbury. So I did an undergraduate degree in behavioral neuroscience. And I started in that trajectory because I just love neuroscience. I love our brain. I love how everything's connected. And really, I was focused on like pain pathways and how there's so many things that we feel in our body, but we only feel it because our brain tells us it's there. So I started in that sort of trajectory and I did my PhD in pain management. And so I did a drug discovery program, again, at Laurentian in Sudbury. And then from there, I was hired on for this clinical project where I'm working with patients with recurrent prostate cancer. And for that, I had to move here to Hamilton. So I started the collaboration between the Northern Ontario School of Medicine and McMaster, but had to move here, which was fantastic. And yeah, I've been working on the clinical trial for a couple of years now. And in that whole process, I sort of shifted over into Don's lab exclusively. So the clinical trial is still my main focus in terms of research, but there's a whole bunch of other things that I'm doing on top of this COVID research as well. So
Yeah, so
Yeah.
before I even knew you were doing COVID research, I know you as doing prostate cancer research. That's what I always like think of in the back of my head because I'm doing breast cancer research. Alden's doing cancer research as well. Like we talked about cancer research before, and then a friend of mine told me that you were doing something related to COVID, and I was like, "What? Okay, but it makes sense because she's in an immunology lab, so
Hmm.
okay, cool." So how did that even like come about? Like how did that happen?
I don't even think I knew I was doing COVID research until it already was started. So it was a very, very um, I am so fortunate to work for Dawn Bodish, who her main focus in terms of research projects are looking at how we age and the aging immune system. So our collaboration with the clinical trial, what I'm doing with Dawn and how I started working with Dawn was looking at how our immune system responds to this therapy. So I take blood samples from patients before, during, and after therapy, and I watch on how we respond and whether those changes are short-term changes or long-term changes, which is really insightful to know how our body's actually responding to a therapy so we know how to make it better.
Hmm.
So with all this COVID research, a lot of questions are coming up with how our immune system is responding, and what are some of the long-term changes because of that. And we know right now that our elderly population is most at risk with COVID-19, which is Dawn's little niche. So looking at the immune system and all these different participants and watching sort of the different responses from people due to COVID, it's going to be really interesting for us long term.
Mm. Okay, cool. Yeah, that is pretty interesting, like how you transitioned just like that. So what specifically like are you investigating at the moment? So you talked about the elderly population. Are you interested in tracking their immune response over time?
So we're doing two different studies right now. So the first one is a serial prevalence study. So what we are doing and what we have already started is we collected a whole bunch of serum samples from men. So we have a good baseline sort of starting population to know what our seroprevalence is for COVID-19. So essentially, when you contract a pathogen or a virus, your body responds to that virus and you start developing antibodies. So we now have a population of approximately 400 people, and that's with collaboration with a couple of other labs in the region, to look at before this infection period, how many people have antibodies that are similar or very are positive for COVID-19. So we do know that we might have some cross-reactivity if we just took like an afterward sample after this infection period to see how many people were exposed. Because right now we have a whole bunch of questions on what's the infection rate of
Hmm.
COVID-19, so how many people are going to be infected, and how many people are going to be asymptomatic versus symptomatic. Right now we only really know of people once you start developing symptoms, but we don't know necessarily how many people are asymptomatic in our population. So yeah, so we have all the serum samples running around like crazy for a couple of days, trying to get as many last participants as we could before this grew into a larger thing,
Wait,
so that we can sort of.
sorry, sorry, continue, sorry.
Was it cutting out? Okay. Um, so with our baseline samples, we're able to look at whether we can optimize all of our protocols properly to know if there's a cross-reactivity to things like SARS or MERS or any of the other coronaviruses that we have in our populations.
So you had to get this done before the complete lockdown. Like how it's not even complete, but before this weird isolation quarantine era that we're living in right now. How did you get 400 people in that time?
So we bled a good handful of people in a couple of days. But again, we're collaborating with a couple different labs here. So all of this wasn't done by our lab
Yeah.
specifically. And we were also part of an aging study over the last 2 years where we have about 110 participants from that we're working on contacting all those people again to see if we can use their serum for this study as well.
Okay.
So all in all, we think we're going to have about 400 people that we could look at before and after this infection period.
Wow. So like what types of samples are you collecting? So it's just the blood and you're looking specifically at the antibody response or antibody production?
Yeah, so we took blood samples, and from the blood we can collect your serum, which is going to be the liquid portion of your blood, so no cells in there. And in that serum, we're able to look at antibody titers for COVID-19. Um, and that's sort of why we need that baseline samples, because we could have a lot of false positives, I guess you can say, to other antibodies that are of a very similar structure, a very similar function. So we want to make sure that we're subtracting out all those with the baseline samples.
So what are you expecting to see from this study? So now, you have the baseline, which is before isolation, and then you're going to test another population of people after this isolation period. Like, what do you expect to see?
We're hoping to get a lot of the same people back in, which is going to be really interesting to know their specifics before and after this infection period. And we're also handing out some surveys to sort of indicate their behavior over the course of this infection period. So did they self-isolate? What was their lifestyle? Did they have other people in their house? Did they think that they were exposed to COVID-19, which is a super important question in a study like this, just to sort of see what percentage of the population did get infected. And again, it's a very local study. All these people are going to be within the Hamilton region. And right now we're doing pretty good in terms of numbers and in terms of infections. But just to get a good idea of how many people are symptomatic versus asymptomatic over this infectious period. Yeah. And how many people at the end of it are building immunity to the infection.
Yeah, I was going to ask that. Like, that was going to build upon my next question about herd immunity. Can you just explain the concept of herd immunity? And do you think it's possible for COVID?
So the idea of herd immunity is that you need a large proportion of people in your community to have immunity to a certain pathogen for protected. So something like influenza during our cold and flu season is a really good example, where we have a vaccine that we put out every year. And with having a good percentage of your community actually being vaccinated, the people that don't respond to the vaccine and the people who are immunocompromised and can't get the vaccine are also then protected, because everybody around them has this immunity to the influenza virus that year. So with the numbers that I've been seeing from COVID-19, we need approximately 70% of the people in our community and in our country and in the world to have immunity, to have this herd immunity effect.
Wow. And
to get that herd immunity, if we just let everybody be infected right now, as it would spread sort of naturally if we didn't do all the self-isolating, we would have so many deaths that's just unacceptable. Just unacceptable to let it run its course. So to actually build up to that taking with everybody's best interests at heart and in mind and public health, we're looking at years to build that herd immunity.
Yeah. Wow.
Yeah. Or we need a vaccine.
Yeah. So, like, how soon do you think a vaccine will be coming? Also, I should say, if you're watching and you have any questions, there's a little question arrow thing down there if you want to ask a question, or you can just leave it in the comments if you have a question for Dr. Kennedy. Okay, sorry, continue.
So vaccine. The thing to keep in mind with vaccines is 99.9% of vaccines that we that end up going to trials fail. So we have a lot of really great companies and a lot of really great resources here in Canada and in other countries to help us develop vaccines. But it takes a really long time, and a lot of trials need to happen to find one that's going to work.
99%
examples of that
fail.
Yeah, it's a huge percentage. And if we think of things like HIV, we've been trying to produce a vaccine for HIV for a very, very long time, and we're still not at a point that we have one yet. So.
Wow. So it's going to take...
It's going to be a process.
Yeah, I've been seeing estimates of 12 to 18 months. Like, is that a realistic estimate? Is that people just being optimistic?
I really don't know. We have a lot of really great resources. We have a lot of really great companies in our region. People are tackling this problem to develop a vaccine from multiple different angles. So there's lots of signs of hope of developing one. But what that timeline actually is, I really can't guesstimate what that's going to be.
Yeah. So as it relates to your research, also, I saw a news article, um, maybe last week, well, sometime recently, where they were using antibodies from people who have recovered from COVID-19 to treat patients who actually do have COVID, who actually have the disease. Um, well, I think they had to wait until there's a certain amount of antibody in the serum for it to work. Do you think um, your study could potentially highlight other areas of research like that?
One really interesting, so the second study that we're doing, which I think is going to be a perfect little plug right here,
Mm.
is we're doing this healthcare worker study where we're working with Mount Sinai in Toronto, and we're doing this multi-site trial where we're trying to collect 1,200 participants in our region. And out of those 1,200 participants, we're going to be collecting blood samples, again, before and after the sort of infectious period. Again, to look at seroprevalence is one of the main goals, to see how many people contracted the virus, how many people are asymptomatic versus symptomatic. And we're collecting people that are healthcare workers because we want to look at the immune response when we actually do get infected.
Mm-hmm.
And that's one of our really big interesting points in our lab is we believe that, so if we look at other sort of respiratory, RSV being one of them, there's sort of two different immune responses that happen to not necessarily tell who's going to be asymptomatic versus symptomatic, but there's sort of this distinction with if you contract the virus and you have this really quick immune response, those people typically are asymptomatic, so they won't show any symptoms, and it's still kind of questionable right now whether you can still transmit if you could still be a carrier of the virus if you're asymptomatic. But if you have sort of this longer buildup before you have an immune response to the pathogen, those are the people that tend to be symptomatic. So what we're doing is we're sending healthcare workers home with all these kits, and we're waiting for them to get sick. And once they get sick, if they do get sick, whatever the respiratory infection is going to be, we're going to get them to swab the noses of the people that live in their house with them. So family members, children, parents, roommates, whoever's there. And the idea is that we're going to watch the other people get sick, and we're going to see what happens to their immune response in the several days before they get sick. So I think that right there is going to give us a lot of insight to how we respond to these pathogens.
Wow, I did. Wow.
Yeah.
So, okay,
Watch and wait.
yeah, so it's basically inevitable that healthcare workers will be, because they're at the front lines, and they are the most at risk, really, for COVID at the moment. So yeah, so you're sending them kits to like for them to test themselves and their families.
Yeah, their family members in their house.
Yeah.
Yeah.
Wow.
So we're trying to recruit 1,200 participants in that one, and we're expecting about 30% of healthcare workers to get infected over the course of the next couple of months, and the has to be at that 50 to 60% of people. Once you look at somebody who's sick, you're also going to get sick.
Mm-hmm.
So by the end of it, we're hoping to have samples from 50 households that had a COVID-19 infection, and then hopefully 50 households with another respiratory infection, that we can sort of determine if this is a similar response to other respiratory pathogens or if it's something specific to COVID-19, and any differences that might show up there.
Yeah. So on the point of being asymptomatic, I've been seeing so much debate about being able to be a carrier, as you said, for COVID, if you don't show symptoms. So a lot of people are saying, so how can you pass it on if you're not coughing or sneezing or what's not? But it's also a fact that it can spread through droplets. Like if you talk and you, I don't know, not accidentally, if you just touch your phone, then someone else touches that phone or like the tap in your bathroom. You're thinking, well, I'm at home, no one has symptoms, it doesn't matter. I don't have to like wash my hands with soap all the time if I'm not going outside. Like there's so many things that you have to be thinking about.
Oh, exactly. And the research is still sort of contradicting whether or not if you are asymptomatic, you can actually spread the pathogen. But the point is just stay safe. Just
Yeah.
wash your hands all the time. We should always be washing our hands. There's other things in the world too that can affect us. Yeah,
Yeah.
buy soap.
Yeah. Lots and lots of soap. Yeah. No, it's really it leaves so much that we have to consider, like, constantly. Yeah. Yeah. Okay, if anyone has any questions, you can drop them in the comments section or in this little question mark little box thing here. I don't know what to call it. But yeah, so are there any other like potential avenues for your research at the moment that you're looking at as it relates to COVID?
I think for us, one of the big questions is in an aging population, how does our immune system change? So we do know that an elderly population does have a different immune response to pathogens and to just, normal things. We do know that our elderly population, they don't respond to vaccines the same way that a young, healthy adult would. And all that's due to the immune response that's generated by a vaccine. And they can't clear infections as easily as a young, healthy person would. So by collecting all these samples from all these different households, we're hoping to just provide some insights on to how that aging immune system does change,
Hmm.
and hopefully to open up some pathways into some future research there as well.
Yeah. Yeah, so you're going to be working on this for quite some time.
Yeah.
Yeah.
It's an amazing team, though. Amazing team of people. Everyone's working so efficiently right now, and it's
Hmm.
so collaborative amongst all the different hospitals and clinics and
Hmm.
academic um, backgrounds. So it's been a really interesting couple of weeks.
Yeah, yeah. And it will continue to be an interesting couple of weeks
Yeah.
after. So how does that work in terms of you having to go to the lab to do your research? Because a lot of our non-essential research, not a lot, all non-essential research has been canceled unless it's COVID related. So what does that look like in a COVID lab?
It's challenging. So we aren't a lab so our lab specifically, we don't typically work with viruses. So it's a lot of big changes in a short period of time to
Hmm.
make sure that we can. We're very fortunate that we work in a really great facility, that people around us do work with viruses, and we do have a level 3 facility available. So currently we're going through training to make sure that we can work with these more dangerous pathogens than what we normally work in our lab. We're working with some, other researchers in the area to sort of collaborate and to optimize all the samples that we have to work together and collecting all that data. But also it's a challenge because we can't actually physically be there right now.
Yeah.
So we're all at home until things become essential, and they become essential when our samples come in. So in the next couple of weeks, I'll most likely be heading back to the lab for a couple of days, but for the most part, trying to figure it all out from home.
Right. So it's just a lot of documentation, paperwork that you have to do. Yeah. Yeah, for us, in biology, if you have animals that you have to take care of, you are considered essential or emergency list. So yeah, I'm going in next week, Monday, to deal with not my mice, but my lab mates' mice to assist with that.
Do you have any experiments on the go right now that you need to go back in for?
Everything I'm doing right now is computer based,
Okay.
thankfully. But yeah, it's mustering up the productivity energy to get it done is the biggest challenge right now. But yeah, I think I have so much data that I just need to analyze right now. So this, in theory, is the great time to do it, but also the worst time to do it.
Totally agree. Because we are an aging lab, we have mouse colonies that we age for 2 years. So we still have people rotating through every now and again to check in on our animals, and we do these long-term studies. So they're collecting some endpoints and some parameters right now. Challenge because everyone needs to be scheduled in on a certain day and a certain time, and It's a very interesting time right now.
Yeah, that's
Yeah.
exactly what's happening with us in biology because it takes
Mm-hmm.
so much time and money and effort to just engineer the specific mouse model. You can't just like get rid of them.
And it's
Like,
so interesting because like if I was still in grad school, if I was in the middle of a project I would have had to stop. I would have been devastated because like we wouldn't be doing research unless it was important, so everyone has this tie that their research is essential. So it's so difficult to give it up, especially when you know that you're going to be falling behind in school a little bit, or it's going to add on a couple more years to your postdoc project. um, in terms of the clinical trial that I work on, we've been really, really fortunate that we didn't have any patients currently undergoing treatment.
mm,
So we're just doing some follow-up visits, which are very easy to move to the phone. And we are going to lose data out of it because we're not going to get blood from those people
yeah.
at certain times. But at the end of the day, it's not worth bringing them in for
Hmm.
just a follow-up visit. So
Yeah. Especially in an elderly population.
yeah, most
Yeah.
of our participants are over the age of 75. Most of them are over the age of 80. So to bring them in for unessential um, visits are just not worth their health. So
Yeah. 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 So it definitely is an interesting time for research productivity for sure. But yeah, thank you for everything you're doing, you and your lab. Yeah. No, honestly,
it's
because
been fun.
yeah, every like there I really can't remember the actual number, but there are so many publications about COVID coming out every single day. Like, like how repository like PubMed is just a repository for all things medical, health, science related. There's a repository just for COVID that includes preprints and peer-reviewed articles. It's really, really interesting. It's
It also presents a sort of a unique situation, though, that all this information is coming out so quickly, and some of the papers that are coming out aren't being peer reviewed in the way that we normally would peer review something.
yeah.
So there's a lot of mixed data that sort of like people are pulling information from. So that's where we get all this mixed information from. Two papers pop up saying something's good, two papers pop up saying it's bad. We have all these clinical trials that aren't controlled in the way that we normally would control them. We're making these big conclusions out of them. So we have to be careful when we start picking those papers to gather this information. And in a time where like day to day we're getting different information about COVID and
Yeah.
how it's spreading and how it's infectious and all these sort of different parameters. So it's
Hmm.
really challenging to keep up with it.
Yeah, and it really behooves us as researchers, especially researchers who are reporting on COVID, to really list your limitations before you even get into the rest of the paper. Clearly list your specific limitations so that you're not misleading people with this big conclusion. Like I've been seeing papers that are just literally like correlations and people are making big claims out of them because like, oh, you have this particular blood type, so or most COVID cases have this particular blood type, which is like, okay, what is this saying? Nothing really. But
But
then
out of your like population of 4 people.
yeah, and then it's just being broadcasted as, oh, if you have this blood type, you're more likely, and it's like, no, that's not true. So yeah, it's a really interesting time. I can't find another word.
Mm-hmm.
It's yeah, just
It's so unprecedented, right? Like I mean, I definitely haven't lived through a situation that it's been this quick. And we've been very fortunate in Canada that we've had the gift of time. So we've had the ability to sort of watch how other countries and other populations have handled the outbreak and have handled certain situations. And we get, the firsthand information in terms of research so we can help build on top of what's already been done. Um, so we're very fortunate that we have a lot of good strategies to
yeah.
contain this and to handle this and to go at it in the right way to keep as many people safe and happy and healthy as possible. Um, so we have to be grateful for that.
Yeah. Yeah. Okay, well, it's time to wrap up. I can't
Okay.
believe the time went so quickly, but thank you
Yeah.
so much,
Oh,
Alliston.
thank you so much for having me.
Yeah,
I again,
Yep.
I've learned a lot in a couple weeks, so
Yeah.
hopefully I presented the information as clearly as I could.
Oh, you
A lot
did.
of it's new and exciting.
Yeah. Did you words that you wanted to leave? Anything else you wanted to add that you didn't get to say? That you really wanted to say?
I don't think so.
Okay.
Just it's going to be a long journey, and try to stay as positive as possible, and everyone stay nice and friendly with each other.
Yeah. I like that.
Chat with Shawn as much as you can. He's awesome and amazing.
Alliston's awesome and amazing. Please follow her on Instagram. And I guess people might still have questions and they could potentially
Yeah,
contact you if they wanted to.
absolutely. Send me an email, send me an Insta, whatever.
Yeah. Okay. Thank you, Alliston.
Thank you.
Yeah.
Enjoy the rest of your day.
Yeah, you too.
Bye.
Bye.